Dr.
Yeah.
Yeah.
Now we will call upon Dr. Supradip Ghosh. He will be speaking on therapeutic options in advanced vasodilatory shock.
I sometimes disbelieve looking at this photograph of mine. Is it mine or somebody else's? Anyway, thank you very much for having me here. So I was given the task of this topic of what are the options we have for advanced vasodilatory shock. So I tried to define how do you define that advanced vasodilatory shock. So I found various definitions. One of the definitions speculated the refractory shock, and they defined refractory shock based on a vasopressor dependence. They defined that if the patients require 0.5 microgram per kg per minute of norepinephrine equivalent, then you define it as refractory shock. But is it what we mean? Second thing I think is very important is something called hemodynamic coherence. Initially, when you resuscitate a patient of shock, any type of shock, we believe that if we improve the macro hemodynamics, whether it is cardiac output or blood pressure, it will improve the micro circulation or micro hemodynamics. So this coherence between the macro and the micro circulation is maintained in the initial part of the shock, but later on that coherence is lost. Exactly when this coherence will be lost, I don't know, and nobody knows. But sometimes this coherence is lost. That time it is hemodynamic incoherence. Probably this can be told, you can call it as refractory shock. So I rather went into a more practical aspect. For example, this patient who presented to us with elderly gentleman with diabetes, presented to us with pyelonephritis and septic shock. And after receiving 1.5 liters of ringal lactate, and after being on norepinephrine around 40 microgram per minute, patient is still having evidence of peripheral circulatory failure. Lactates are elevated, capillary refill time is more than 6 seconds, and there is no urine output for admission. So I believe probably we mean this when we discussed about this topic. So what are the options we have this type of patients? So therapeutic options we have are optimizing fluid. Maybe we can have some options of fluid. Optimizing the MAP target, I'll be emphasizing on this. Catecholamine sparing agents. This patient is on norepinephrine. Can we try other catecholamine sparing agents? Methylene blue has already been discussed in the previous talk. There is an option of hydrocortisone. Is there any role of ascorbic acid, or is there any role of blood purification, which has already been discussed at length by Dr. Rajesh Pandey in the previous session? Let's go to the optimizing fluid. So I love fluids and I dislike them both. So whenever we go for fluid resuscitation, there are three questions we must answer. The first question is obviously if the patient is there any evidence of hypoperfusion? Like this patient had evidence of hypoperfusion. My second question is if we give fluid, a bolus of fluid, does the cardiac output improve? Whether we'll be able to improve the cardiac output after giving this, what you call fluid responsiveness. So as we know, fluid responsiveness at this stage is present only in 50% of the patients, and 50% of the patients may not be fluid responsive. So if you give fluid, we actually overload the patient. And we know from Andromeda shock that as the time progresses, patient's fluid responsiveness status decreases. Third question was Pradeep was emphasizing on is the VAXs, whether the patient is fluid tolerant. If you give fluid, whether the patient will be benefited or rather patient will be harmed by the fluid. So we need to do the VAXs or some sort of fluid test of fluid intolerance for this. Fortunately, and we know from this beautiful study from South America where they have shown that almost 30% of the patients who are both fluid responsive and fluid unresponsive, 30% of them in both groups can be fluid intolerance. So even if the patient is fluid responsive, we should not give fluid in such patients. And fortunately, for people who have learned ultrasound little late like me, VAXS is quite difficult, but you can actually rely upon only one parameter of VAXS, which is the portal vein pulsatility index, which is as good as overall VAXS, especially the intrarenal vein, as Pradeep has stressed upon, is quite difficult sometimes in a spontaneously breathing patient. Anyway, so this is what we can do. Second option is, can we optimize the target map? We have seen in the sepsis palm study where two different map targets were given to patients, and they found in subset of patients who are chronically hypertensive, if they give them a target of 80 to 85 millimeter mercury of MAP, they have a better renal outcome, right? So why not we utilize it in our day-to-day clinical practice? So in the Andromeda shock trial, Glenn Hernandez and his team, what they did is a patient, initially you keep a MAP target of 65, 60 to 65, but if the patient still continue to show evidence of hypoperfusion, you titrate the MAP in norepinephrine in such a way to increase the MAP to 80 to 85. Okay, something like vasopressor challenge. So you increase the vasopressor dose and see whether after increasing the MAP, your hypoperfusion improves or not. If the hypoperfusion improves by either decreasing the lactate or improving the capillary refill time, you continue to have 80 to 85 as your revised MAP target. Maybe this can be one strategy. This has been used in a randomized control trial called Andromeda shock trial, were published in JAMA in 2019, so this can be utilized. Catecholamine sparing. We all know norepinephrine is now the preferred vasopressor of choice based on several data and based on the so-called surviving sepsis campaign guideline, the dictum, norepinephrine. But the problem is norepinephrine, like any other catecholamine, they are tachyarrhythmics. We have seen in the sepsis pump study, increase in the incidence of atrial fibrillation if you increase the dose of norepinephrine, and any other epinephrines. They are thermogenic. They produce metabolic disturbances. We know from the study by adrenaline versus norepinephrine study from the Australian group, where they have shown that increase in the hyperlactatemia incidence with adrenaline, it can be there in the norepinephrine also, and it can produce hyperglycemia. And excess vasoconstriction, we see it very not very uncommonly, that can produce various tissue ischemia, including mesenteric ischemia and peripheral digital ischemia. In fact, people are now propagating using beta blockade, which was popularized by this fantastic but somewhat very unexpected finding from the 2013 Italian study, where they found that osmolar infusion targeting a certain heart rate can actually improve the mortality outcome. Recently, we have seen the Lendiolol study, both published in JAMA and in intensive care medicine, which has not shown any mortality benefit. But yes, we need to get away from the catecholamine to probably to the non-catecholamine things. So what are the options we have? We have options like vasopressin. We learned that vasopressin versus norepinephrine, there is not much of difference, both in the the Venice study and in the VAS trial. Both in that, there is no difference in the mortality. But one thing we have noticed, if we start the vasopressin very early, how do you define very early? When the dose of norepinephrine is less than 15 microgram per minute. If you start vasopressin, it can have some mortality effect, as has been seen in the VAS study. Venice study, no difference in mortality, but vasopressin early use can reduce the RRT incidences. So there may be some benefit of vasopressin, early vasopressin. Angiotensin 2 is another thing which is coming up. No randomized controlled data comparing effects on mortality, but yes, angiotensin 2 can improve the mean arterial pressure by peripheral vasoconstriction as well as by volume expansion through its aldosterone receptor activity and direct action on renal tubules. The Athos 3 trial was published in NEJM in 2017, where they have shown that early angiotensin 2 can decrease the requirement of vasopressor significantly, but it did not show any mortality benefit. And again, they have shown that if you start this angiotensin 2 early, how early? When the norepinephrine is less than 0.5 microgram per kg per minute, it can actually potentiate the effect significantly. So if you want to start early. I'm not going to the methylene blue. It has already been covered extensively in the previous lecture and previous pro and con debate, but it has got a potential, but be careful because it can produce hemolysis in G6PD deficient patient. And sometimes we usually routinely do not send G6PD for all of our patients. And it can potentiate serotonin syndrome, as the chairperson was talking about. It can potentiate serotonin syndrome in the patients who are already on SSRI. Be careful about methylene blue. There is one other option of hydroxycobalamin. It has got physiological rationale. but evidence are unfortunately very, very limited as of now. It can increase blood pressure by direct inhibition of the nitric oxide. It can inhibit the inducible nitric oxide synthase, and it can also decrease the vasodilatation by eliminating the hydrogen sulfide, which is an intrinsic vasodilator. But we still do not know its efficacy in reducing the catecholamine dose, its efficacy in which particular subgroup of patient we can use this. What is the right dose? So far, most of the studies, they use 5-gram bolus over 10 to 15 minutes. And we do not know what is the synergy of this compound has on other things. But this is one thing which we can look into. So again, our old good hydrocortisone, most of us, we use it. But as I was talking in one of the sessions that earlier in some other thing, that some of your examiners may like it, some of your examiners may not like it. So be very careful when you answer about hydrocortisone. So hydrocortisone can augment the response to catecholamines. It can reduce the inflammation mediated vasodilatation. We know that both relative and absolute deficiency of septic shock of cortisol is there in patients of septic shock. In a previous session, the chairperson was talking about etomidate induced adrenal insufficiency, which we do not routinely. Many of the patients septic shock, you give etomidate for intubation, pre-intubation, but we do not know what is the effect because patient is already on norepinephrine and other things for that. The controversy is not that the hydrocortisone is good or bad. Hydrocortisone can definitely reduce the vasopressor duration in all the studies. These 4 large randomized controlled studies, that can reduce the vasopressor duration, and as well as it decrease the but in controversy is whether it reduces the mortality or not. 2 of the studies, the first one published by Jilale Anand in 2002 in JAMA, and again approaches study again led by the group led by Jilale Anand. They have shown the combination of hydrocortisone plus fludrocortisone can reduce the mortality when it is used very early, as well as when it is used in a very, very sick patients. But other studies, Corticus and Adrenal, has not shown the mortality benefit. But one thing is clear, use hydrocortisone early at a dose of 200 to 300 milligram a day. It will definitely reduce your vasopressor requirement. Ascorbic acid is a interesting thing. It's a key antioxidant. We all know that it's a cofactor for conversion of dopamine to norepinephrine and for the synthesis of vasopressin. We know that it has positive effect on the chemotaxis of neutrophils. So in 2017, the grand old man of critical care, Professor Paul Marik, published a paper in Chest. It was a retrospective analysis of 94 patients with septic shock. And he has shown that there is an unprecedented mortality benefit observed with a cocktail of hydrocortisone plus ascorbic acid and thiamine. So probably this paper could be published just because the first author was Paul Marik. So if you go through the paper, there are a lot of fallacies of this paper. But because Paul Marik has said the gospel truth, so a lot of randomized control trial was published based on this assumption that ascorbic acid, with or without the other parts of the component, will improve the mortality outcome in sepsis. So CITRIS ALI study was published in patients with sepsis with ARDS. They show the primary outcome was not different between the 2 groups. The primary outcome was organ dysfunction. It was not different whether you give vitamin C or do not give it. But in the secondary analysis, they showed that there is a decrease in the 28-day mortality in ascorbic acid group. So our enthusiasm for ascorbic acid increased further. So many other studies, but one of the important one was a vitamin study, which was published in JAMA in 2020, where 216 patients were compared between HAT regime versus hydrocortisone alone, and they did not find any difference in mortality as well as in the vasopressor free days at day 7. And the ascorbic acid now should not be used probably based on the publication of this study in Lovid study, where they found that in patients with septic shock, if you give ascorbic acid at a very high dose of 20 milligram per kg body weight, that means 1.5 gram Q6 hourly versus placebo, it actually increases the worsen the primary outcome, that is the composite of death and persistent organ dysfunction at day 28 in the vitamin C group. And we also have observed the higher mortality in vitamin C group at day 28, as organ dysfunctions were also higher in the vitamin C group, but that was not statistically significant. So we have a potential adverse consequences of vitamin D. So there are other options we have, correction of acidosis, whether it will improve. We don't have any randomized controlled trial data, but we know that catecholamines responsiveness significantly decrease when the pH is less than 7.15. We probably need to explore this further. There is a role of calcium, but we still need to, because it may augment the vascular tone or MAP, but we need clear evidence, further evidence for this. There is some, I don't know, some role or no role for extracorporeal blood purification. At least one good study by Euphrates study has shown that it has no role. And we may have some role for ECMO, but we still need to find out the things. So my take home message is optimize fluids and vasopressors, consider both FR and FT, fluid responsiveness and fluid tolerance when we go for fluid therapy. You need to start vasopressor early. How early? When the diastolic blood pressure is less than 50. When the diastolic blood pressure is less than 50, start the vasopressors along with fluids, because the coronary perfusion depends on the diastolic blood pressure. If your diastolic shock index is more than 2.3, diastolic shock index is defined as heart rate divided by diastolic blood pressure. Again, you should start the vasopressor early. When the pulse pressure is very wide pulse pressure means patient is extremely vasodilated. Start the vasopressors early. I'm not still telling that you should not give norepinephrine. It remains the drug of choice, but we should consider other agents. Like catecholamine sparing agents. So far, we have role for vasopressin and angiotensin 2, but there are some emerging role of hydrocortisone as well as methylene blue. But we should start methylene blue very early. A recent randomized control trial from Mexico, published in Critical Care in 2024-23, they have shown that if you start it early, within 6 hours of septic shock onset, at a dose of 1 gram 2 gram perfused, 2 gram infused over a 6 hours period for a duration of 4 days, it can actually improve the outcome. Hydrocortisone definitely has some role for reducing the vasopressor dose, but we do not know whether the mortality decreases with hydrocortisone. We still do not know whether the adding fludrocortisone made any difference or not. Definitely there is no role of ascorbic acid. Thank you very much for your kind attention, and thanks the organizer for having me here. Thank you, sir. Thank you. So if because I'll have to leave because I have a flight to catch. If you have any questions, I'll be ready to answer this question for next 30 seconds.
If any comments or questions are there, you can ask.
Thank you very much.
Thank you.
Thank you. We'll move on to